المفروض اليوم عندكم محاضرة فارما بس دكتور نصر بدل، فتجي محاضرة بكرة هسه بعطيكم إياها، وبكرة بيعطيكم محاضرة الفارما. أوكي؟ صارت lots of changes. يلا يا صبايا شو بتنتظروا؟ ادخلوا واقعدوا. It's time to change. Why should you change? Because اسمع هذا الكلام تلبس ذهب. اسمع. Next year, اسمع. Next year you will cross a line. You will cross a line ما بين collecting and understanding knowledge and applying it. So there is some change, right? So it's time for change. So let's prepare you for that change. You know where to put the stethoscope. You know where are the areas of listening to the heart valve. You have studied them, you have seen pictures about them, right? Now, when you cross the line, you are going to use it. You have to know which area to use to listen to which valve, because you've had it, so you apply it. Either the patient will be satisfied with you, or he will be mad at you. It depends on your attitude, whether you apply your knowledge or you don't. It is not enough to remember. You have to understand, apply, analyze, evaluate, and create. You have to do all these mental activities so that you go upstairs to reach your goal. No more colored pictures. No more labeling. Thank you for the drawings, because we have learned a lot. Now we have to enter the real world. Sections of CT scans. Abdominal part of the esophagus. Now we have learned the relations of the esophagus, how it goes through the mediastinum, perforates the diaphragm and gets into the abdomen. The abdominal part is very short, maximum 4 centimeters, and it joins the stomach. If you look at this barium meal, here is the abdominal part of the esophagus joining the stomach. This is the cardia of the stomach. The part filled with gas is the fundus. Usually the fundus is full of gas. Where is the esophagus? You go to the vertebrae, okay? You go to the aorta, and you see it just lateral to the aorta. Nice, rounded, collapsed tube. Where is the esophagus? Is the posterior, anterior, that's the liver. You see the head and the chest of the patient is away, it's behind the screen. And you see a section, and This is the stomach, okay, filled with barium, and you know that the esophagus makes an impression on the liver. So this is the lowest part of the esophagus. This is the gastroesophageal junction. It enters through this opening, which is made by the right crust of the diaphragm, turning around the esophagus. And when you go and enter by an endoscope to the stomach through the esophagus, this is what you see first, and then this is what you see later when you inflate air. Okay, that's the upper esophagus. That's secretions in the esophagus, and then when you go lower down, although here there is esophagitis, you can see the stomach. The stomach has different arrangement of mucosa. This is something you have seen before, the sudden change of esophageal stratified squamous epithelium into the columnar of the stomach. This is called the Z line. If it is disturbed, then it is Barrett's esophagus. Here is Barrett's esophagus. This is the stratified squamous non-keratinized epithelium of the esophagus, and this is the type of epithelium of the stomach. Now we have studied this junction and what are the factors producing safety factors for preventing reflux. This is a cadaveric image of the esophagus, and which has a longitudinal fold, and then the sudden change of color, and then the rugi of the stomach. This is a previous knowledge. You know this very well. Well, I'm not going to go through it. These are the different parts of the stomach. Now we want to examine the stomach. This knowledge is also available to you. You know these 9 regions. Okay? So this lady is examining which organ. Her hands are pressing on which region? Epigastric region, right? Upper central part, because this is the umbilical region. And what do we have in this epigastric region? This is what? Costal margin. This is costal margin. And this is the costal margin. You see, the liver should not be beyond the costal margin. The lower margin of the liver should be just at the costal margin. And this is what occupies the epigastric region. It is not the fundus of the stomach or the body of the stomach. It is the pyloric area of the stomach. This hand is examining what? Epigastric region. So it's pressing on pyloric area of the stomach. When the endoscope goes into the stomach, this is the normal folds of the stomach. Why should I have folds? These folds are longitudinal because the stomach is dilatable structure. جوعان انت بتروح تاكل اللي الله قاسمه when the stomach here full and goes down to the pelvis because it's dilatable structure. If mucosa is not folded, then you have problem. But these folds are spare structures to allow distension. Nice, healthy, shiny mucosa of the stomach. This is not normal because you can see that there is something wrong here. And this is early gastric ulcer. This is what you see in a barium meal. This is the gastroesophageal junction. You can see two lines marking the gastroesophageal junction. These arrows are indicating fundus of the stomach. This is the body. This is the antrum. This is the pyloric sphincter. This is the greater curvature. This is the lesser curvature. This is previous knowledge. Again, going through previous knowledge, cardia, fundus, body, pyloric area, greater curvature, lesser curvature. Stomach is opened, and you can see that this is the pyloric antrum, and this is the pyloric sphincter, this is pyloric canal. Pyloric sphincter is when the circular muscle of the stomach collects and makes a bundle of muscle running circularly and makes the pyloric sphincter. This is also previous knowledge. It tells you that the parts now we know. It tells you that there is a lesser omentum going to the liver and a greater omentum hanging down. Closed pyloric sphincter, opened pyloric sphincter. Physiologists will tell you how this sphincter is going to, how it's going to open and close. We have an X-ray like this in the lab, so you should know the parts of the stomach by barium meal. Here there's something funny. This is the body of the stomach, and these are the rugae, the grooves between the folds. But if you look here, the barium has went into a pit and did not empty. This is what is called ulcer crater. So this is a diagnosis of gastric ulcer. Again, when you give more barium and you wait, the barium will fill the stomach and then fill the duodenum and goes to the jejunum. This is a CT scan of the upper abdomen, where you can see this is the liver, stomach, and spleen. Note that this is mainly the right lobe of the liver. The left lobe goes across the midline and covers the fundus of the stomach. That's the liver, that's the stomach full of barium. اقعد اسمع لك كلمة كلمتين. بكرة سنة رابعة لما تترك المحاضرة قول الله يعين. And this is the spleen. So the question is, where is the stomach in the upper part of the abdomen? It is between liver and spleen. Again, this is the stomach. ولا بيردوا ولا بيسمعوا. Right. This is the stomach. This is air in the stomach, usually in the fundus. This is different parts of the lobes of the liver, something we'll be talking about later. And this is what? This is the spleen on the left. Again, this is the stomach. Now, when we take coronal section, the stomach is described as a J-shaped, and you can see the J-shaped structure of the stomach, covered by the left lobe of the liver. In the upper part, this is the stomach, and then this is incisura angularis, this is the pyloric antrum, and this is pyloric canal opening. This is the stomach. Rather thick mucosa. This is a sign of gastritis. Here you can see the rugi. The rugi are wide. Therefore, this is a case of gastritis. Where's the stomach? Here's the stomach. Fundus full of gas. Okay. Lying to the left of the midline, and then the part of the stomach going to the right is the pyloric part to join or to continue as the duodenum. That's the stomach joining the duodenum. Why is this stomach? You know, because first of all, it is containing barium, and there is gas in it. Why is this the duodenum? Because it is to the right of the stomach, and it is not as big as the stomach, and it contains barium as well. Therefore, this is the first part of the duodenum. That's the stomach for the same reasons, and this is the duodenum for the same reasons. This CT scan is showing that if you go around, well, air in the stomach is normal, but if you go all around, you see that the stomach wall is uniform, but when it gets here, it gets thicker. This is cancer of stomach. In a cadaver, this is the stomach, okay, covered by the liver. So you lift the liver to see the stomach. You see the liver has a sharp edge, and this is the pyloric area. This is the lesser omentum extending from the lesser curvature to the liver, and this is the greater omentum hanging down from the greater curvature. This is also cadaver. The green line is indicating the greater curvature, lesser curvature. And this is fundus, body, pyloric area, pyloric sphincter. This is the lesser omentum, and this is the greater omentum hanging down. This is the pyloric canal when it is opened. It opens into the duodenum. The inside of the stomach has folds, longitudinal folds called rugae, and it has an extra third innermost layer of muscles called innermost oblique. This is previous knowledge. You know that. The gastrointestinal tube is made of inner circular, outer longitudinal, but the stomach has an extra oblique. Blood supply of the stomach is mainly coming from the celiac trunk that gives the left gastric artery. Common hepatic will give the right gastric artery. The gastroduodenal gives right gastroepiploic, and splenic will give left gastroepiploic and short gastric arteries or short arteries. Why I am showing you this? Because there is no infarction in the stomach. There is no infarction of the stomach because these arteries anastomose. If you lift the stomach up, you will see pancreas, splenic artery, splenic vein, and beginning of portal vein. Veins, they follow the arteries, but drains to the portal system, not to the inferior vena cava. It drains to the portal system. The stomach needs nerve supply. Why should it need nerve supply? Because, first of all, you need to modify the muscles. Nerve supply is sympathetic and parasympathetic. Smooth muscle, when you increase the parasympathetic activity, the activity is going to increase. The sympathetic is going to decrease the motility. Plus the glands. You see, if a person has duodenal ulcer, that means he is producing large amount of acid, and the glands are having nerve supply. Therefore, if you cut the vagus nerve, the nerve coming to the glands, secretions will be less. So it receives the left vagus and the right vagus. Lymph nodes, also multiple lymph nodes, and that is a big problem. Cancer of the stomach is going in different ways, which is going to confuse us. And the stomach is deep. But these are the major lymph nodes draining the stomach. When you go to the duodenum, this is the duodenum. It's a C-shaped first part of the small intestine. It begins by joining the pyloric sphincter. That's the first part. This is the second part, descending. Transverse part of the duodenum and ascending part of the duodenum. All these parts are retroperitoneal. And then there is a ligament called ligament of Treats, T-R-E-T-Z. This marks the end of the duodenum and beginning of jejunum. The jejunum has a mesentery. So the mesentery starts here, and there are recesses around the beginning of this mesentery called paraduodenal recesses. Patient brings barium and you start taking X-ray, and it is going to show different parts of the upper gastrointestinal tract. This constriction is the pyloric canal. This rounded part is the very first part of the duodenum, and it is called duodenal bulb, usually the place of duodenal ulcer. Then the second inch of the duodenum. So the upper part of the duodenum is equal duodenal bulb, the first inch, plus second inch of the duodenum. This is the descending part, horizontal part, and the ascending part. This is a previous knowledge. You know this very well. Previous knowledge. Again, this is when you go by endoscope into the duodenum, you see circular folds. These circular folds are called plica circularis. They are there to increase the absorptive surface. Into the duodenum, we are going to receive bile from the common bile duct and pancreatic secretion through the pancreatic duct, which are going to open into what is called major duodenal papilla. This is an endoscopic image of major duodenal papilla. Another one and another one. This is in a diagram, the major duodenal papilla. On the inner border of the descending part of the duodenum. Here is a scope going into the duodenal papilla to pick up a stone. A procedure that can be performed. And here is the stone taken out through duodenal papilla. Again, different parts of the duodenum. The bulb is triangular or pyramidal in shape. If we see coronal CT scan, is the descending part, the horizontal part, and the ascending part. And this rounded structure full of barium is the stomach, is the liver, this is the diaphragm, and this is the heart. The stomach pyloric part goes to the right to become continuous with the duodenum. That's the descending part of the duodenum. That's the descending part of the duodenum. The duodenum here is marked green. In a cadaver, this is the opening of the junction between the stomach and duodenum. and this is the first part. Then we start having the descending part, and then the horizontal part, and then the ascending part to join the jejunum. Inside this C-shaped duodenum, you find the head of the pancreas, and to the right laterally is the right kidney. This is the superior mesenteric artery supplying the parts of small intestine. This is the major duodenal papilla, where the common bile duct and the pancreatic duct open. The common bile duct, as it comes down anterior to the pancreas, posterior to the duodenum, and then shares the ampulla of Vater with the pancreatic duct and opens into duodenal papilla. That's the stomach, that's the duodenum, descending part, and this is the pancreas. Same image. Where are we now? This is the horizontal part of the duodenum. Small intestine, it is small because the caliber is smaller. Fills most of the abdominal cavity, covered by the greater omentum, which is lifted, and it's made of duodenum, jejunum, and ileum. This is what is called barium follow-through. When the barium passes, the peristalsis passes it to most part of the upper GIT. This is the stomach, right? Which structure is this? This is the duodenum. You can see that the feathery-like appearance is characteristic. Which part is this? That's the jejunum. The jejunum is the place of maximum absorption, therefore it has wider lumen, longer villi, more blood supply, so it gives this appearance. So that you compare this appearance here with this one, it is different. Now if you apply your 9 regions of the stomach, when you want to palpate the jejunum, where do you go? Left lumbar region. Okay. Then, which part of the small intestine is this? This is the ileum. You can see different X-ray appearance indicates the different height and density of this plica circularis. You will have this in the histology next few lectures. So the duodenum appearance is different from the jejunum, and it is different with the ileum. Where do you palpate for the ileum? Suprapubic area. Okay? Then you start to see a different image. This is different from this one. in this one and this one. You can see that there is, on the outline, there are these house striations, and the lumen is much larger. This is what you see, small intestine in a cadaver, different parts, layers of the small intestine. Here's a coronal CT scan of the abdomen, and you apply your knowledge. Large intestine, you want to recognize a large intestine, what do you look for? You look for gas, you look for larger diameter, and you look for position. صح ولا لا؟ Okay. يعني around the umbilicus أقدر أشوف large intestine. The answer is no. Okay. So this is small or large intestine. This is small. Okay. This is small intestine. Small intestine. This is what? This is large intestine, because it has large diameter and there is gas in it. This is large intestine. Larger diameter with gas in it. Again, this is the ascending colon, where you can see it has a large lumen and multiple areas of gases. This is the liver, this is the gallbladder. This is the stomach. This is the liver. This is small or large intestine. This is small intestine. The surgeon is holding the small intestine up, where you can see the mesentery, 2 layers of peritoneum, so transparent, and you see blood vessels. Blood supply to the different parts of small intestine is different. It starts with an arcade. Okay? Starts with an arcade. They come from the superior mesenteric. It is one arcade in the jejunum and a branch that goes to the jejunum, and there is no anastomosis here. So if you cut this one, or this one is blocked, then this area of the jejunum is going to be infarcted. The stomach does not get infarction because there is anastomosis. يا هانم اتركي التليفون. اسمعي شوفي. التليفون تقدرين تشوفيه بأي وقت. In the ileum, there are multiple arcades. So it is harder for the ileum to get infarcted. This is an image of infarcted jejunum, where it dies and gets black. It has to be taken out. Here we are talking about junction between terminal ileum and the cecum. Now we can put an endoscope. The endoscope goes down through the esophagus, stomach, and some part of the duodenum. Cannot go more than that. Colonoscope is a scope that goes through the rectum, sigmoid up, transverse colon, lower down to the cecum. What about the small intestine? If I want to see what is going in the small intestine, where there is a camera, the patient will swallow this camera, and the camera will send images. And there are different brands of these cameras. The patient is going to swallow this, and the camera is going to send different images of the small intestine. Here it is sending the the ileocecal valve. The major blood supply of the small intestine is the superior mesenteric artery. The large intestine, this is an old knowledge, previous knowledge, starts with the cecum as blind pouch, ascending colon, hepatic flexure, transverse colon, splenic flexure. Transverse colon has a mesentery. Descending colon, then sigmoid, which has a mesentery. This is cecum, appendix, ascending colon, transverse colon, splenic flexure, descending colon, sigmoid, and the rectum. The rectum has two turns to the left. Why is this large intestine? Because there are these haustration and this fatty epiploidy, tags of fat tissue attached to it, and there is tinea coli. This is tinea coli. This is large intestine, this is small intestine. And these are the haustrations. This is tinea coli, these are the fatty tags. This is small intestine. This is large intestine. Large intestine under cover of the liver is hepatic flexure. Here is transverse colon. On the left, these are parts of splenic flexure and descending colon. This is small intestine, this is large intestine, and this is large intestine for the reasons we have just discussed. What comes out of the cecum as a blind pouch is the appendix. كل شوية واحد يطلع. This is the root of the appendix stemming out of the cecum. You can see that this is tinea coli and this is the cecum. And this is the appendix. That's the tip. And this fat is the mesentery of the appendix. Also, this is the appendix. In this barium enema, the appendix is filled with barium, and this is quite large appendix. This is a CT scan showing a normal appendix. Look at the wall, it's thin, and there's air in it, and everything looks nice. Again, normal appendix, normal appendix. Here things are not all right. The wall is thick. The wall is thick, not like this one here. The wall is thick. Okay? And again here, two sections of the appendix, you can see how thick the wall is. This wall is inflamed and it starts to have a reaction around it. Here's the appendix, and it's a collection of fluid around it and part of the greater omentum. Lower down, there's the rectum. End of sigmoid, and then the rectum and anal canal. The rectum is not covered by peritoneum. It has these three folds of mucous membrane to separate feces from gas. And this is the anal canal, and you have two sets of sphincters. Internal sphincter, which is the continuation of the inner circular, and the external sphincter, which are skeletal. These are the folds of the rectum, and these are what are called columns of Morgagni, and this is the anal canal. In embryology, the large intestine stops here, and the anal canal starts from outside and goes in, and they meet. And a membrane remains, but at the moment of birth, this membrane is broken. Sometimes it doesn't. These columns of Morgagni, they contain veins. Okay? And the junction between the endoderm of the hindgut and the ectoderm of the anal canal is called dentate line. Now there are lots of veins here. Heart disease or any other disease, if they pull down one of these columns, the patient is going to have fissure in the anus. Or if one of the veins is going to be dilated, it comes out as hemorrhoids. You will see lots of these cases. This is a CT scan where you can see that this is a large intestine with contents, but this is the rectum. The rectum goes posteriorly, and this is the sacrum. And then this is the lower part of the sacrum, and this is the rectum full of air, prostate gland, and urinary bladder. Thank you.